The next talk is by on EDOFs. Are they the stars on the block? Dr. Jayaprasad.
Good afternoon. Thank you. So in the search for an ideal IOL, we have seen that monofocal IOLs give best uncorrected visual acuity at a fixed distance. Multifocal IOLs, both diffractive and refractive, give good vision at fixed distances, but with significant photic phenomenon, as the previous speaker said. And there is always a compromise, a reduction in the contrast sensitivity. So there is a gap to fill, a new model with a balance between an uncorrected distance vision, an uncorrected good intermediate vision, continuous focus, and with less of photic phenomenon. And for this, EDOF lenses were considered. The idea was to create a single continuous elongated range of focus from far to intermediate, and if possible to tweak it a bit and to increase to get better near vision with absent or at least reduced halos without affecting distant vision. To call a lens EDOF, the American Academy of Ophthalmology has come out with various criteria. Very difficult. None of the lenses available today have gone through this criteria, and they can say for sure that it is an EDOF lens. Because here the optical surface should be continuous, the profile should be continuous, there should never be a change in transition, it should be equally diffractive or refractive. And it is not a pure EDOF lens if you have added a diffractive element, if you have added power for a near vision, and if you use chromatic aberration for getting this effect. So what are we using? What are the basic principles used in getting an EDOF lens? See, when we were using monofocal PMMA lenses, we used to get 612 N6 when you have a residual astigmatism of say -1 diopter 90 degrees against the rule. Then you get 612 and N6. Patients are extremely happy. No price, just 300 rupee lens. 612 is more than enough. Nobody is sitting and staring at the stars. But these phenomena, corneal and IOL aberrations and small pupil size, these are the basic principles which are used in manufacturing EDOF lenses, and we have classified George Elio, the famous refractive surgeon from Spain. He has classified it into 5 groups. The first one, which is a pure EDOF lens, where the spherical aberration is manipulated. And here the classical example is Pure C, and previous one was Minivel. It is not available in India. That is what I believe. Then we have small aperture IOLs, where reducing the size, we know that if you reduce, you will have depth, acufocus and extra focus. Then we have lenses with low near vision addition, multifocal lens, but they will give only a small near vision addition like the Atlara from Carl Zeiss. Then in Symphony, Synergy and Suprafob in focus. Suprafob in focus was designed by JK. And that is actually once again a combination of multifocal with EDOF. And then we have central part of the lens modified for nearer vision, as in eye hands and vivity. George Elio classifies eye hands as an EDOF lens. Let us look at Pure C. This is supposed to be the type 1 of this. It's a refractive EDOF lens with no rings. The anterior surface is aspheric design, and posterior surface they will keep it a secret. But basically the shape of the radius of curvature of the anterior and the posterior surface are different, like your natural crystalline lens, and they tweak it a bit so as to get better intermediate vision. So these patients get functional near vision, high contrast sensitivity, there are no rings, and minimum halos and glare like 5%. Remember that all lenses have glare and halos. Monofocal lenses 5%. So this matches monofocal lenses. And this may be an ideal lens if you are planning to put an EDOF lens in a patient who has mild retinal pathology or glaucoma. Type 2 lens, EDOF lenses are ones where you have smaller aperture lenses. We have acufocus and extra focus. Now this is very, used to be popular in Europe, but not anymore I suppose. They ask you to put it in one eye and the other eye monofocal. So here, because the aperture is smaller, you have more depth of focus. The disadvantage is less of light enters the eye, so contrast sensitivity is definitely reduced. And remember that you have got a peripheral ring scotoma. And then Zeiss came out with Adlara lens. Adlara is once again a continuous diffractive design with low power addition. It's not a real EDOF lens. Then came in 2014, Symphony came into market from J&J. It's actually a diffractive lens, diffractive EDOF lens with multiple rings on the back, an aspheric anterior surface. Multiple rings on the back means definitely there will be glare and halos, but it gives good visual acuity across all distances. And then they further modified and reduced the rings to 15 rings. Once again, this gives less of photic phenomenon and it's better in mesoptic conditions. Then in India from Appasamy Associates, we had this hybrid multifocal EDOF combination where this is essentially a bifocal refractive lens with an EDOF profile. The central zone of 1.2 diopters has a plus 3.5 diopter addition. So you have got a small bubble in the center. If you see the lens, you will identify. The posterior surface is aspheric. So George Elio says it's not a real EDOF lens, but it gives good clinical results in my hands. I do use Indian lenses. And type 5, the final one is where the central part of the optic is modified, the profile is modified. The two examples are iHands and the Vivity from Alcon. Here the variation, the geometry of the central optical zone is done, but both the companies do not really explain the real optical principles in this manipulation because they do not want their competitors to know about this. iHands is marketed as an enhanced monofocal. It has an optics with increasing power from periphery towards the center, but there is no demarcation line as the classical definition of an EDOF lens, and has a tiny central 1 millimeter plateau for intermediate distance. It gives excellent distance vision as good as a monofocal lens and has a low potential to induce photic phenomenon. Majority of my cases I use iHands and iHands alone. And Vivity from Alcon, once again it is where they use a word called X-wave technology, where in the central 2.2 millimeters they have modified. So you get some stretching of the focal point to a focal distance so that you will have some amount of depth of focus. Less of halos, but 17% still. And there is always a reduction in contrast sensitivity. Now please remember EDOF lens or whichever multifocals are there, please don't get carried away by marketing. This is one advertisement which came in last year's ESCRS conference. They have put it up even in front of the washrooms, saying that this has got low glare and halos. And always remember that when you open up the pack and look at the leaflet, you will see that they are all written in very tiny letters, like what the insurance fellows and the loan fellows will do. So magnify and read for yourself, but to the patient you can tell them that this is what is written, but always remember to get informed consent. And who should choose EDOF lenses? Individuals who prioritize clear distance and intermediate vision, those who drive frequently, particularly at night, who work on screens, engage in dynamic environments, who needs uninterrupted vision is essential, who are sensitive to visual disturbances like halos and prefer a shorter adaptation time, and they don't mind using spectacles for near. Please remember, don't put it into a neurotic patient's eye or 5 types of personality. As if you ask any psychologist, don't put it into a neurotic patient's eye and a patient who will not adapt. And listen to the patient, find out what he or she wants, and there is no free lunch. When you get something, you have to give it back, and always get everything in writing. And this EDOF is a junction where we have arrived. From here, we have to go to accommodative lenses, really good accommodative lenses, and I think it is not very far away when we will reach that. Thank you very much, and let me also tell you one case that I had. 15 years back, multifocals done bilaterally, 6/6 and 6. It was a homemaker. She said she has no problem with halos. So I implanted bilaterally 6/6 and 6. She was very happy. And at the age of 60, she went and got a driving license. Thank you very much.
Thank you, JP.